All right, so I already made one paramyxovirus video, and that was to go over kind of structure and replication. So for anything regarding the genome or the replication or how it differs from orthomyxoviruses, which you definitely need to know, check out that video. Now we're going to talk about the actual viruses in the family. So we're going to talk about respiratory syncytial virus, parainfluenza, measles, and mumps. All right, so let's start with RSV. Um, RSV is actually a fairly serious virus. This is the most common cause of fatal acute respiratory tract infections in infants and young children. Specifically, children under the age of 2 are at kind of increased risk to this particular infection. And then to top it all off, it's highly contagious. So I got this infograph from a JAMA patient page, and I really like it because even though it's obviously showing the infant coughing, but one of the things that I think as, parents and caregivers that we forget is that when you're holding a baby, when you're cradling a baby in your arms, your face and the baby's face are very close. So mom, dad, grandma, grandpa, well-meaning neighbor and friend is holding the baby and goes, excuse me. And they're going to take their opposite hand and cover their mouth. And that's going to shoot whatever they cough into their hand directly into the baby's face. You're going to need to find a different way of blocking that. So I want you to just kind of a little mini public health initiative there. Um, it also can be actually a significant disease for elderly people because elderly people actually also have kind of a similar immune response to very young infants. Okay, so RSV produces an an infection that is localized in the respiratory tract and then produces syncytia. The disease is caused by a viral invasion of the respiratory epithelium, which is exacerbated by damage caused by the immune response. So this is one of those viruses where the immune response is actually kind of a bad guy. So what happens is the bronchioles actually become plugged with mucus and fibrin and necrotic material, basically as the bronchi and bronchioles begin to necrose. And in infants, those airways are so tiny and they can easily become obstructed, and that's what actually leads to death. And then to top it all off, it's just kind of immunologically a mess. Natural immunity is really not protective in this case. It doesn't even protect the poor little baby from reinfection. And part of that could be due to the young age of the population. So the immune response isn't that good, the memory cell isn't that potent. And actually, when there was a vaccine that was developed, and they actually found that with this killed vaccine, it actually appeared to enhance the severity of disease, not ameliorate. So, therefore, it wasn't really recommended. It can be a really severe disease. Approximately 1% of RSV infections require hospitalization, but it's so widespread that approximately 95,000 children in the US will be hospitalized with it every year. So this is certainly not one to mess around with. Like I said, it's highly contagious. It's spread in respiratory secretions. In fact, this whole lecture should just be called Things You Get from Respiratory Secretions. And basically, for many days during and after the infection, the infant can still spread it. It's transmitted on aerosols, but also on fomites, which again, for babies, that's a big problem because what do babies do? They put everything in their mouths, and so they're just creating little infectious vectors. So an introduction into like a nursery or especially an intensive care, like a NICU, that could be devastating and is associated with considerable morbidity and occasionally death. So what's the clinical syndrome? So I have it here. Really, it can be anywhere from the common cold to pneumonia. You're going to see rhinorrhea, which is really common in adults and older children, whereas a more severe lower respiratory tract infection with bronchiolitis occurs in infants as the bronchioles become inflamed, leading to a decrease in ventilation. And then the patient probably will have like a low-grade fever and tachypnea and tachycardia, and then you'll see wheezing of the lungs, and then the disease can be fatal in premature infants, patients with underlying lung disease, the immunocompromised population. If you're going to diagnose it, it's a virus. You're going to use RT-PCR, maybe immunofluorescence, maybe ELISA. Those are all options. In healthy infants, there's not really a specific treatment for RSV. For most patients, they're going to improve within 1 to 2 weeks. You cannot treat it with antibiotics. It is a virus. You can use things like oxygen therapy, fluid, nebulized cold steam. Ribavirin has shown some effectiveness in really severe disease, but it is not frequently used. And then there is also some prophylactic and therapeutic passive immunization with anti-RSV IG, which is available for children that are in really high risk for serious disease. All right, parainfluenza. It's the flu, but it's not. It can cause anything from mild to severe respiratory tract disease. And common colds to feeling like you got hit by a truck. There are 4 serotypes. 1, 2, and 3 are the most common causes of disease. And in fact, 1, 2, and 3 are actually second only to RSV for important causes of lower respiratory tract infection in infants and young children. So in kiddos, this one can be pretty rough. It's associated with bronchitis and can often be referred to as croup. If none of you have ever had croup, I had croup a lot as a kid. In fact, if you're an asthmatic, you tend to have a higher incidence of croup. Croup is kind of this seal-like bark. And if it was, November or December, I would happily demonstrate this for you. You probably, if you're going to school at my school, you probably won't interact with this material until we're in like flu-like season. So you've got a good shot of hearing this because people with croup make this kind of loud barking cough. What else? So you do make an immune response. IgA does appear to be a bit protective to this one, but there are patients that even despite making a good response and it normally being mild, can wind up with pneumonia with this one if they have trouble clearing the virus. Patients with it sometimes get coryza, pharyngitis, a mild bronchitis, wheezing, bronchiolitis, and pneumonia. The incubation period is about 2 to 6 days, and most children actually recover in about 48 hours. So it's a pretty quick one. Diagnosis, it's a virus, so you could do RT-PCR. Normally, it's not even diagnosed, though, because for the most part, it's self-limited. There's no vaccine, but for patients who have some significant difficulty breathing, you might consider nebulizer treatment to kind of help open up those lungs. All right, measles. This one I want to spend some time on. It's sometimes known as rubeola. It's one of the 5 classic childhood exanthems, along with rubella, also known as German measles, roseola, which is caused by a human herpes virus, 5th disease, which was named 5th disease because it was the 5th childhood exanthem, and that one's caused by parvovirus, and chickenpox, which is caused by varicella, also a herpes virus. It is one of the most common and unpleasant viral infections, and it does actually have serious potential sequelae, post-infectious sequelae as well. Prior to 1960, when the vaccine really got underway, more than 90% of the population younger than 20 years of age actually experienced it. The vaccine is actually the MMR and now MMRV vaccine. And it is a great vaccine. It protects against all sorts of things: measles, mumps, rubella. So those 3 all in one. And in recent years, varicella has been added to it, and that's drastically reduced the measles rate. Unfortunately, though, these days, measles is making quite a comeback. In 2017 alone, we had 119 cases, several cases in Illinois, where many of us are located. I believe there's been some cases this year already. 2014, that was the year it hit Disney, and there were over 600 cases that year. When you look back to 2010, when there were only 63. I mean, these numbers are, I mean, that's a doubling. Um, this is the vaccine that kind of came under the most fire. Um, and so this is kind of the effect of that. All right, so how does it get in cells? Well, it binds to CD46 on most cells. It can also bind to Nectin-4 on epithelial cells and CD150 on B cells and T cells. It is able, like all of the paramyxoviruses, to cause kind of a cell fusion phenomenon, which creates giant cells and syncytia, and it also allows it to kind of directly pass cell to cell, and therefore it kind of escapes antibody control. And this one actually goes lytic as it replicates. Eventually, it lyses out of the cell, which obviously can be very damaging. It does have this significant post-infectious sequelae in the brain, and that's called SSPE. And we'll talk about this in your neuroblock. It's subacute sclerosing panencephalitis. And what happens is a patient who had measles, 10, 12 years ago, suddenly we get behavior changes in handwriting, and most people go like, well, yeah, now he's a teenager. Teenagers are weird. And then the patient starts having seizures. And then what happens is that we find out that there's this kind of non-replication competent persistent measles infection in the brain that actually leads to this pathology, and that is 100% fatal. So that is one of the severe sequelae. Thankfully, it's very rare. It's like 1 in every 200,000 cases, and we're not seeing that again yet, but it is something that can happen. It's highly contagious. Respiratory droplets, again, man, I mean, I understand, wear a mask. I don't know. If people vaccinated, that would definitely shut this down again, and thankfully many people still do. The virus will replicate in the respiratory tract, but if it infects monocytes and lymphocytes, that's when it spreads systemically and causes viremia. Okay, so let's talk about the clinical syndrome. Systemic infection of the virus actually leads to infection of the conjunctiva, the respiratory tract, urinary tract, small blood vessels, lymphatic system, central nervous system, everywhere. So that's kind of what I'm showing here. So you get inoculation of the respiratory tract and local replication, but then once it gets into the lymph, it's gone in your blood, and then it's everywhere. The virus-infected endothelial cells and the immune cells together lead to the formation of the rubeola rash. So that's kind of this characteristic rash. And actually, if you put rubeola, roseola, and rubella right next to each other, that's kind of difficult to distinguish. So at some point, I'll show you all of these images, and I want you to be able to differentiate measles from rubella from roseola, because they're very, very different. So this is the characteristic maculopapular rash, and like I said, that's due to the T cell response. Most people are going to recover following the rash, and that's going to lead to lifelong immunity. However, some patients develop a post-infectious encephalitis, or that SSPE I was talking about. Some patients also develop pneumonia, and obviously pneumonia can be deadly. So this one is kind of a serious one. There's kind of I don't know, a way this tends to work, and I'm showing that here. There's this incubation period that's anywhere from 7 to 13 days long, and then you get the prodrome. And the prodrome is actually going to start with like a high fever, and then you're going to get cough, coryza, conjunctivitis, and photophobia. And then you also get these guys. These are Koplik spots, and they look like little grains of salt on the buccal mucosa here. So the disease is most infectious during these kind of early prodrome symptoms. 2 days after the prodrome, that's when you see the Koplik spots appear, and you might see them, they're kind of deep, they're back by the molars, and then you get lesions showing up, and they kind of stay for a couple of days. About 24 hours after the Koplik spots, that's when you get the rash. That spreads all over the body, including the hands and face, and that might take 1 to 2 days to make its trek across the body. And then eventually, after, about 2 weeks, the rash goes away, the respiratory virus goes away, and hopefully the patient recovers. Sometimes they move on to encephalitis. Sometimes they move on to SSPE, and sometimes they move on to pneumonia. Pneumonia is a serious complication, and it accounts for about 60% of the deaths caused by measles. And it's similar in incidence to the other complications associated with measles. Encephalitis only happens in about 0.5% of measles case, but the fatality rate is pretty high. It's 15%. I just realized I forgot to do diagnosis on the last slide. For measles, diagnosis is typically based on clinical manifestation. You shouldn't try to isolate it, but respiratory tract secretions, urine, blood, and brain tissue all contain the virus. You can analyze it by RT-PCR. In an unvaccinated patient, you can actually use IgM. And that can be detected once the rash is present. There's no specific treatment, but there's a great vaccine. Mumps, hey, that vaccine works for mumps too. So you could kind of knock both of these out with one shot. So mumps is the cause of a pretty acute and benign viral parotitis. Basically, that's a really painful swelling of the salivary glands. It's rarely seen in countries with high vaccination rates. And as with measles, we've seen an increase in mumps in recent years, which I'm showing here. 2015 looks relatively low, but if you're from Illinois, there was actually a pretty comical, well, not comical, I'm sure not to them, but a large outbreak down at the University of Illinois in Champaign-Urbana, where basically they had a case of a patient with mumps, and they didn't think it was mumps, because who expects mumps? And the kid had been vaccinated. And then within kind of a week, like 5 to 10 students all showed up at the health center, and it turned out they had mumps. And really what it was is all these kids had been vaccinated, but they'd been vaccinated when they were children, when they were like 3 or 4, and now they were 20. And so the vaccination had waned. So they needed kind of a booster, and then that shut down the response. There is only one known serotype of mumps, and it does cause lytic infection of the cells. So we're going to see cell lysis. It initiates infection in the epithelial cells of the upper respiratory tract and then spreads to the parotid gland. The virus is spread by viremia kind of throughout the body. You can find it in the testes, the ovary, the pancreas, thyroid, and other organs. There are actually, you can also see it in the brain and the CNS. You see infection of the CNS and meninges in about 50% of patients. It's said that if you get it and you survive it, you have lifelong immunity. But I think that stance is being somewhat questioned, because we are seeing kind of some pop-up flares of mumps. Transmission. This is another one of those respiratory droplet aerosol diseases. Living or working in close quarters promotes the spread of the virus, which makes sense. And incidence of infection is greatest in winter. Why? Because we're all inside together, hanging out. Mumps infections are often asymptomatic, but if it does manifest, you're going to see a bilateral swelling of that parotid gland with fever. The onset is pretty sudden, and sometimes you can see swelling of the other organs in too, like meningoencephalitis. This picture is actually of a poor Pittsburgh Penguins hockey player. Apparently in 2014 in the NHL, mumps just kind of ran wild. And I guess there were several members of the NHL who had not been vaccinated. And, they're all sharing water bottles in close quarters. And, probably, spitting and whatnot on the ice. I was a figure skater, and I certainly ran into my fair share of that on the ice after a hockey game. So actually, many teams and many players were affected by this NHL mumps outbreak. So hopefully they've gotten that under control. So recovery from the virus, it's not one that tends to be deadly. Like I said, it's generally pretty benign. You can actually recover the virus from samples. Samples would include things like the saliva, urine, pharynx, CSF. It's found in the saliva for about 5 days after onset of symptoms. Clinical diagnosis is generally confirmed with PCR or ELISA, and you can also look for serology in unvaccinated patients. And those are the important paramyxoviruses. Get vaccinated.